Nipper, if you could start the recording.
Okay, yeah, if you could start the slides, and I think we just wanted to finish kind of some introductions that we started last time, and ask the HMA folks who are here to introduce themselves to the work group. Janine, do you want to do that?
Sure. So I'm Janine Smith. I'm work with Health Management Associates, with a consulting firm of which we have a Portland office, and been there about 5 years, working with a variety of states and tribes and other entities on health reform and policy and practice transformation. I formerly was hired originally by John Santa at the state of Oregon 20 years ago, and worked there for 15 years, including many of that working under Bruce. So it's like deja vu, and did a lot of things, including setting up the patient-centered primary care home program and working on the CCO development, etc. And my colleague is Janet Meyer.
Janet?
Hello. Hi, my name's Janet Meyer. I've been with HMA for about 2 years now out of the Portland office. Most of my work has to do with managed Medicaid across the nation. I have somehow become an expert in the Texas Medicaid program, which I will tell you makes the Oregon program look 24 karat. That is not a state you want to go to for Medicaid. But before I joined HMA, I worked for about 18 years in managed Medicaid here in Oregon, prior to CCOs, post CCOs, and had the great pleasure of being part of the startup team for Health Share of Oregon back in 2012.
And our third colleague is Nora Leibowitz, who is not on this particular meeting today. She also worked in a variety of health policy roles at the state, including a lot of time spent on the health insurance exchange, and has done policy work at HMA for the last 5 years in that arena and other parts of health reform. So she's helped supply a lot of some of the research for today's slide deck.
Okay, thank you, Janine. I would point out that we have asked Chadwick to be here, and I think Chad is here. Thank you, Chad, for—
You're welcome.
Chad has been the chair of the provider reimbursement tag, and so it's great that he's able to join us. We also have some guests coming. I think Michael Collins has joined us, and Michael's here and will make some comments when we get to a discussion about the tribes and sovereignty, and appreciate that. And I think we all know Michael from the task force, so I think we're good there. So first slide is the agenda, and you see we're basically starting our march down our charter and trying to accomplish the tasks that are in that charter. With that, Laurel, can I turn this over to you?
Please, that sounds great. I don't think there's a need to kind of dig in further. Let's dive right in here to our first agenda item today, which is a discussion of continuing this discussion of values. Where we left things last time is you all actually were able to engage in a relatively robust discussion of values right off the bat in your first meeting, which was fantastic to see and witness. I took a stab at taking the comments that you all made and pulling them together into a values document. I shared that document with all of you over Google Docs and asked for some feedback, some comments. I have not yet received any feedback from any of you. And so really what we wanted to do here is kind of check in and see, you know, this was an attempt to kind of integrate both the values from 770 along with some other pieces that you spoke to. What do you all want to be doing in terms of next steps? Would you like to take a stab at editing this in between this meeting and the next meeting, or do you feel like this is sufficient for your purposes? John, I know that you and I kind of checked in back and forth on this over email. Is there anything else that you would like to add in terms of where we're at in this values discussion?
Well, my own personal opinion after reading it was I'm a little bit worried that there's too much there, but I don't want to wordsmith at this session, and I don't want to spend tag time wordsmithing. You know, what usually moves me the most is a single sentence, and if somehow we could, you know, capture 5 single sentences that summarize each of the elements that are up there, I think we would make it easier to kick off the important discussions that eventually need to follow by various successor efforts. And so that's where I'm at. I'd like it to be shorter and take the language out that most grabs and most captures the folks we're trying to work with.
I think that's a good suggestion. That maybe all of us should, or whoever wants to, sort of send you a 1 sentence or 2 sentence. Are you saying 1 sentence instead of 5 like that? And if so, we can all just try to do that. I mean, I see some ways to cut it back. I particularly like, and when I read it the first time, I saw the single payer will invest in local communities. To me, sort of brings in the upstream issue, which I thought was nice.
Yes, yeah, you know, what I would prefer, Chuck, would be 5 single sentences.
Okay.
Or 6 single sentences, none of which, you know, duplicated. They each addressed a single really important thing, you know, rather than a paragraph. Because I think folks will be more likely to read it if it's shorter, if it's each is single sentences versus paragraph.
I wonder, hearing you kind of frame it that way, John, it seems like there really is there is a core value to each of these sentences. Right. Improving health, you know, access to healthcare being fundamental, distribution of resources, transparency, and this kind of investment in local communities. Do those 5 kind of value elements, do they accurately kind of summarize what you all are envisioning for this document? Like, would it help to kind of try to pare down by honing in on those 5 elements that I just...
Well, it does for me. I mean, to tell you the truth, I look at this slide and I go, oh, I'm good with that.
Yeah, this slide as opposed to the full document that...
Yeah, this slide works better for me than the full document. And I realize that, you know, that leaves out some details that are important to folks and all. But, you know, when it comes to communication, we're increasingly a society that is more influenced by just the right amount of language.
Yeah, to those 5 points you said, Laura, I would just add equity and dealing with disparities.
Yeah.
You know,
yeah.
And that's what I would hone it down to.
Yeah.
Yeah. I as I was reflecting on what I said, I was trying to think of what what Deborah would say. I realized we should probably note that Deborah was unable to join today's meeting. She is a member of this tag as well. And I am confident she would be honing in on that piece.
And that piece is in the language, not on this slide, but in the document. But
well,
I would agree.
On the slide.
I would agree the word equity is not there, and so it should be. And
Yeah.
let's figure out where to put it.
So I'm happy to kind of take a stab at using this slide as kind of a guiding framework for wordsmithing these 5 larger values statements into tighter language. Does that feel like the right next step? I see a thumbs up from Chuck, a nod from John. Bruce, thumbs up, great.
Okay.
Love it. So I'm actually going to hand it over then to Janine, who's going to be presenting the bulk of the slides remaining.
Great. So the first topic we were going to spend some time on is kind of to clarify the role of this new, what currently is being dubbed a single payer entity. And this slide outlines, and you should have seen these when you got the slide deck earlier, some of the roles that are sort of unique to this, as opposed to, say, a regional entity or the delivery system, et cetera. What are the unique roles of the single payer is what we want to narrow down and define. So examples are sort of what we would be termed reserve powers that are sort of unique, that is the responsibility of the single payer, managing finances and stewarding the resources. So establishing all aspects of the global budget is an example. Lead cost control efforts, support regional economies has come up. Then there's the role of overseeing the program itself, the operations, ensuring that it's that things are happening. They may or may not be the ones doing everything, but they're at least ensuring that there's quality operations, quality to the claims administration, financial management, data collection, et cetera, good member education and communication. And then there's policies, setting sort of the rules of the road as you move forward into the single payer. They'd be setting those policies and ensuring that there's something that they're being implemented. And there's a couple of examples here, doing regular strategic planning, determining coverage for certain things, including monitoring and addressing changes to healthcare as they evolve over time. And then those would be the first 3. Then there's supporting the delivery system reform and improvement. What are they wanting to drive? Much like Oregon has been doing to date, is trying to drive change. How would they continue to ensure that there's a movement away from fee-for-service to value-based payments? How would they continue to monitor and track spending and utilization of the delivery system? Really, again, having this role of oversight. And then equity is certainly a key role for them, to make sure that that's happening, to achieve health equity, so that as you're improving access, quality of care, it is in an equitable manner. Workforce development, making sure there's an adequate workforce moving forward, including what those needs are, how to achieve them, and what kind of training, funding, et cetera. And then there's sort of the keeper of the population health-based financial information system, all the stuff that's going to be happening in this one single payer world. They would be the resource and source of that definitive data. So those are sort of some potential key roles that we with John had felt were some of the top ones to consider. And so I'll open it up to see whether any of those resonate or don't resonate with folks as to what their vision of the role this single payer plays.
Janine, it resonates with me. I guess my only, not to sort of wordsmith, but just to clarify, when it comes to information and data, that last piece, I would think it's not just the keeper of financial information, it's utilization, quality, population health, et cetera. I think that's sort of assumed in some of the other categories, but might just, we want to be clear about that.
Right.
Not
Okay.
good at that. Yeah.
And I'm not sure how to word it. Hey, Chad's there. I'm not sure how to word
I've
this.
been here all along.
Oh, I'm sorry. But, I think people are envisioning that they have better sort of consumer protection and consumer access. And so I'm not sure if it be the place where people can go for that help. If someone isn't happy with the care they're getting or how they're being treated by the regional entity or whatever.
So do you think that would fall though under sort of overseeing the administration of the program?
Yeah, probably. Just sort of, yeah.
So
As I said, I'm not sure how to word it. I just think that's.
I think of performance review. If we're going to have these regional entities, there's going to be a role for oversight of performance, and that's a very broad term.
okay.
Which can be defined later.
So that could fall under program administration, as well as, I suppose, the reform and improvement roles.
Yeah. I think so. They may want to frame social determinants of health goals or other kinds of things.
Other thoughts? There's a part of 770 that says kind of to define that cost containment role a little further. So we're going to have the next slides focused on that. But so we didn't go into a lot of detail here up on that first one where they lead cost control efforts.
So I have a question about on the supporting workforce development. You're seeing it as sort of identifying the needs and shortcomings and whatnot, not actually necessarily funding it, but it would be the place, an important player in sort of saying, hey, our community colleges we need to up our game on getting nurses or whatever.
It could be that. I mean, also in many ways, the state has done that to date by expanding the role and developing and expanding the role of, say, community health workers. Then the state set up a whole certification process. It was part of our original agreement with the feds that we move forward with that model. There are, not just that we need to crank up nurses, but think about how to diversify and potentially shift tasks. I mean, some place that thinks about it.
Right. My point is, would it be the entity doing that training and whatnot, or just thinking about it and pushing for it?
What do you guys think?
Yeah, I mean, I think, Chuck, this is the first of many times we'll ask ourselves, well, so to what degree should the delivery system do this, or the single payer, or something in between? Now,
or the CCO like entity.
Right. That's the something in between.
Right.
And interpreters is a good example. Oregon has done a fantastic job of working in Medicaid to promote interpreters being present and playing a more active role. That's a real workforce issue.
Right.
And so, you'd have to decide, does the delivery system want to find those people, hire them, organize them? Does the single payer want to do that if the delivery system doesn't? Or an organization in the middle?
Or continue it being OHA, right? So.
Right, and setting policy, encouraging incentives, etc., can help to fuel some of this as well. As they started to be able to bill for community health workers, for instance, then there was more push to hire and train community health workers. So,
yeah.
Okay.
So what I hear so far is probably something around member appeals, or I'm blanking on the right word, that might fall into program administration, some sort of
Well, it's customer service, it's
customer service.
communication, things of that sort.
Okay. So here, some addition to that, probably under overseas program administration. Incentive, maybe a little refinement. Support workforce development. Does that sound like the right terms based on the discussion we just had?
Yep.
Yeah.
Okay. And expanding the keeper bullet. I can't think of a better word yet than keeper, but to expand that beyond financial information, but utilization, quality, other types of information. Other thoughts on this particular potential roles? Any roles that aren't listed here that you think we're missing? No, not hearing anything. Well, maybe we can, maybe they'll come up as we go into the next. Can you move to the next slide, Laurel? So this was a more specific aspect of 770 that we wanted to kind of pull it out to kind of better refine this cost containment role. These were some potential ways that single payer would have its role of ensuring administrative simplification occurs, not necessarily them doing it per se, but trying to inspire it. Designing payment structures. We did say on the other previous slide that they would be establishing all aspects of the global budget. So they would be set, how the payments they'd be sort of, and I think John used it as they're the ones kind of the bank and sending the dollars out. And then any administrative costs. And then techniques techniques for the regional entities to use at the local level. So this would be maybe potentially driving value-based purchasing incentives, the way Oregon currently is in the process of trying to do through both their CCOs and through the Total Cost of Care Compact with the multi-payers. Setting utilization control policies. How will you manage the services that are to be delivered to keep it cost effective? Some rate setting, multi-state purchasing. This certainly could come into be with pharmacy, much like we currently do in Oregon with the Oregon Prescription Drug Program. Or there are many other legislative initiatives around, say, drugs. And then, of course, the fraud, waste, and abuse aspects. So does this seem like a potential list of sort of this, under cost control, these would be some more specific roles?
I think, Janine, the one bullet I would object to is, because we're not there, I don't think we should be saying that global payments are going to regional entities.
I agree.
We have to wait and have that discussion. I mean, I personally think that there should only be two organizations who money's going back and forth, and that's the single payer and delivery system entities. And I think 770 is pretty clear that there should be no risk-bearing entity other than the single payer, or when it's a hospital, there's a global payment. When there's a physician group, there can be capitation. And I'm in favor of that. I think any third party that actually has to handle large amounts of money and then move them on somewhere else is going to be costly and create issues. That's not to say that there wouldn't be a payment to a regional entity for helping out with a variety of different tasks that the single payer wasn't positioned to do, and the delivery system wasn't either positioned or didn't want to do.
John,
Oh, go ahead. Jeff.
the only thing I would add to that, I would agree with you, John. As we've discussed, we really don't want to create insurance entities at the regions. I would like to have a vehicle. I think it's important that in terms of roles that the single payer is the designer of the incentive system. And so I'd like to have something specifically that refers to that. I'm also interested in somehow having a vehicle for some upside retention and some sort of way to create incentives at a decentralized level that can improve performance and get new things going. So I don't know quite how to do that except maybe as a retention.
So,
Or as a bonus payment or something.
so they would be designing, so the overall bullet is designing payment structures. So that would include incentives to drive delivery system change, correct? And that could be, those incentives could be in a variety of ways, shared savings, downside risk, correct?
And even a reward for certain performance indicators that the single payer may be interested in seeing achieved.
Right.
Vis-a-vis social determinants of health, performance, or other things.
Right. So you'd want to take the language out that specifically says they're going to give global payments to regional entities, but put in more vague. In general, they're going to sit down and figure out how to get the money out and what kind of incentives they would tie. Or, incentives.
I think you can say global payments to delivery systems adjusted for reduction in administrative.
Yeah, that's fine. I agree.
Okay. And then creating incentives and other potential approaches in working with the regional entities as well as the delivery systems, correct?
I'm interested in performance improvement at the regional level. And so some sort of way to have the single payer be creating things that encourage people for various performance improvement activities that single payer may want engaged in.
Yeah, so I think that techniques for regional entities probably needs to come out, but maybe it's more development of performance improvements or some, yeah. And probably broadly. So, so is that, how does that resonate?
Yeah. Now Chad had mentioned, I don't know what the best wording for it is, but creation of a transformation fund. And because in some of this might be, incentives, but some of it may be creating infrastructure. In parts of the state, we don't have much infrastructure around primary care. How are we going to get to that?
Or even supplemental RMPs or other areas of labor that they may need.
Right.
Well, you do have the role earlier on the past slide about support for the workforce development.
Yes,
so
that's right.
So this is more in terms of dollars flowing here, and both cost containment and creating incentives.
Right.
I agree.
I wonder if designing payment structures and rate setting are redundant.
Yeah, I was thinking that too.
Yeah.
Now that we've sort of broadened it a bit.
What you might say for that bullet is the capital funding issues.
So replace we'll add rate setting to the payment structures. And what's the term? Determine capital investments, capital.
Well, it's really organization of a capital investment system.
John, I think we've had a lot of discussion about capital, and I think the reimbursement tag sort of felt that there was a distinction between that capital, which should be really part and parcel of their reimbursement process,
right,
and elements of capital which fall more into the idea of a certificate of need, or where the single payer may not want to have competing investments in a particular regional area. So, I would sort of break it up personally into that category. I don't think the single payer wants to be involved in all the capital of a delivery.
I agree with you.
Yeah, I know Vermont, for instance, has been engaged. Their Green Mountain Board does deal with certificate of need at that higher level, but not at each individual hospital investment, I don't think.
Right. Janet, you have a
Yeah, I'm wondering if some of this conversation really belongs under the global budget design, because that's where the decisions about capital investment will come. How much of the global budget will be set aside for that versus how much of the global budget would be available for incentives or shared savings versus the cost containment role, which I thought we were trying to focus more on, reducing the cost and the trend over time versus how we're going to use the pot of money that the tax finance, or however we're financing the system. I'm just wondering if we're starting to combine those two concepts.
Yeah, and I think the single payer has an overall global payment system. This says payment structures, and so actually you're pointing out, because I was kind of thinking, well, this is the global payment to hospitals, or the global payment to the delivery system. When there's a bigger global payment above that, and I agree with you that that's maybe where the capital piece should be, especially because I think Chad's point about differentiating that, we're not going to get into telling delivery systems what they can do in terms of capital improvements.
So are you suggesting potentially it's, we have on the previous slide the fiduciary,
so maybe it's
reserve powers that said that have established all aspects of global budget, and some of what we just have been talking about.
Yes.
Probably all falls under that sub bullet.
Yes, I think so.
And then there's some of these other things, lead cost control efforts, and some of these other things such as utilization control would be more specific, be more, setting utilization control policies, multi-state purchasing,
right,
preventing fraud, waste, and abuse, all sort of fall under that lead cost control efforts bullet.
Yeah.
And again, this cost containment roles are not unique roles that we would add to the list. They're sort of, it was more to get a little more definition around cost containment.
Yeah.
So we can adjust some of that. Again, what we talk about today is going to come back around in a format for you all to look at and see if that agrees with what you were talking about. And then you would have, we'd officially, more finally bless it next meeting. So it was sort of our approach to these.
So
today.
that actually makes me think now, Janine, that we can get rid of organization of capital investment, because it's not really a cost containment strategy.
Right.
Yeah, we just get rid of that. I took us down.
The only thing that would be a certificate of need program.
Right.
Yeah.
Which has variable impacts, but is certainly a role that some consider important.
Yeah, if you invest in the wrong systems, you could actually increase costs.
Right.
Yeah.
And there might be pressures to do that, whether you call it certificate of need or whatever, but
Right.
there's things that you may and may not want to invest in.
Right.
I think what Chad was talking about earlier was that right now capital is funded through insurance payments. A portion of an insurance payment is considered to be for capital. And when those go away, where do the facilities get their capital budget? So that's the what part that goes up to the global versus how many MRIs do we need in Hepner?
Right. I mean, I see it as I think that negotiating reimbursement, whether global budget or whatever the approach is, ought to include capital that is defined in a certain manner that's kind of the small to medium facility specific capital. That should be part of the negotiation for reimbursement, and that should be their responsibility to figure out. For those elements that are large and costly and community, we don't want community duplication, then we should find a way to define those out and say they're specifically not included in your reimbursement, and they're negotiated in a separate manner, sort of.
Is that what others would agree?
Yeah, I would. I think that's. I hope we're capturing that, because I think that's important.
Okay.
So we are talking about the single payer getting involved in the large capital investments, and so that could include information systems, big buildings.
It could. Actually, it's an interesting concept. It definitely could, and certainly it should include things that improve access for the population at large, because we may want to locate certain diagnostic or certain things in certain areas that historically have not had access, such as the tribes or something like that.
Right. Right, and it gets a little bit at this issue of, so what if a hospital says, well, we want to do this or that, and we don't need your money. We've got our foundation, and we're going to fund this or that through our foundation.
Well, I see that as a regulatory matter, and I think that if the state is going to engage in this, we're calling it certificate of need, that they should prevent these sort of side deals from being done by entities, specifically by law.
We'll come back to that.
Otherwise there's going to be a big workaround here.
Yeah. Well, I think there's a sweet spot. It's it's a little bit. We've talked about, hey, our public schools are public schools, but some of them get significant donations from parents, and to the degree that they're willing to share that with other schools in their system, I think that could be a positive. On the other hand, if it resulted in inequity, then it's a positive becomes a negative.
Right.
So
yeah, I mean, it is true that it could improve access if they're allowed to go ahead and do their own thing, as long as the state is engaged in sort of applying their funds in a manner that improves access. So I guess there's a sweet spot there, John.
I think we need to find that, because it's clearly an issue on cost containment, separate from access. So, And I
It
can't
is,
tell,
but
a lot of people in this area say, look at, Salem Hospital keeps building and building and building. That's why my healthcare costs go up.
Yeah. Or, this probably will stir things up, but, when Phil Knight gives OHSU $250 million for a heart program that doesn't deliver, so then he gives $250 million to Providence for a heart program. The public watches, wow. Those are a lot of assets that aren't being managed very well.
Well, the finance and revenue tax is going to tax them out of them, so we won't need the donations.
I'm glad you said that, Chuck.
It's the John Santa tax. We call it the John Santa tax.
I think it might be hard to say that the role of single payer is to prevent donations from wealthy Oregonians, but.
Well, they can go to that. I mean, we do need to make sure that the single payer can accept donations. I mean, that is something we have to make sure is in one of the details of the law. So, seriously, that's just.
Okay, so these ones, with exception of the designing payment structure that sort of folds in under one of the previous roles on the previous slide, those other ones, admin sim, setting utilization control policies, potentially some sort of oversight of capital via like certificate of need, and we'll need to maybe get some information on back to you guys to help sort that one out a little bit. Potential multi-state purchasing efforts would be guided by the single payer, and then preventing fraud, waste, and abuse. Those seem like the right set.
For now.
Okay. So I think the next part of that is sort of that role of the single payer versus our tribal nations that we have around the state. And so this is sort of a brief refresher for what many of you are very well familiar with, is that the tribes, they are separate and unique sovereign nations. And this predates all of us and much of the state and government. And there are federally recognized tribes in Oregon, and 9 of them are listed here. But they have the authority to self-govern. And to date, there is, regular contact. We put into your background materials a summary slide deck from the OHA on their more detail around this, as well as that they, seek consultation with the tribes before entering into many things, and as well as regularly around many things that touch both the state and the tribes. Medicaid waivers, for instance, they need to have tribal discussion before we launch into those as well. So the next slide is just a point that is often confused by many, and probably not all most of you probably already know this, but while there is an Indian Health Service, or IHS, it does provide funding for tribal and urban Indian health programs, but it's a small budget. They do not receive enough funds to meet all the needs of American Indians and Alaska Natives, barely even half. And so a large number of the tribes, either they'll actually buy insurance for their tribal members. Some will ensure that they are getting onto Medicaid or the exchange, or help facilitate getting them to other forms of insurance, because they know that will complement. I know working in a remote Aleutian Island village, in order to be able to afford to fly someone out of there to get them into Anchorage for care, we would have to, make sure that they had other insurance, because the IHS budget was pretty tight for those expensive flights, as just one example. But so those were sort of, and that was the second part of your background materials, was kind of just pointing out the importance of having insurance. So I think that Michael had joined us, as well as our other speaker, Laurel, or other guest.
I haven't seen Sharon
Okay.
join, as Sharon and Michael are both, as you know, members of the task force, and we invited them here just to see if there was anything that they wanted to offer or kind of supplement in addition to this information, and just offer their thoughts.
As we think about the role of the single payer entity with the tribal tribes, how do we want to define a comment about that so that it's not lost in the thinking around the single payer entity and its roles and responsibilities?
Can I ask a historical question? Are the CCOs, is my understanding that the CCOs do encompass part and parcel of the tribes? Is that correct?
About half of tribal members on Medicaid are seen in CCOs, but CCOs.
But the CCO catchment area, like as I understand it, half of this, our Central Oregon takes half of ours takes half of Warm Springs, and another one takes half of Warm Springs, for example. Is that correct?
Can we maybe let Michael explain that? I think.
Yeah, I'll let it go.
Yeah, that's exactly why, to give us those kinds of perspectives. Michael, do you want to weigh in?
Yeah. So with the question of those patients here in Warm Springs that are enrolled in Medicaid with OHP, here in Warm Springs, 75% of our population is on an open card, and only 25% are with Pacific Source or another CCO. So here in Warm Springs, we're about 75% on open card. And of course, we do have some that switch back and forth from open card to CCO, depending upon the services that are provided. So there's some benefits to having the open card to get services, and then in some instances, such as dental and behavioral health, it's more beneficial to be in the CCO.
Michael, could you give us a sense of all 9 tribes? To what degree do across the tribes they have their members are patients in the CCOs or open card, and their provider clinics are participants in the CCO or not? You follow me?
Yeah, I follow you. So here in Warm Springs, we don't have a contract with the CCO. We do communicate with Pacific Source, with their liaison, and but we choose not to have a contract with a CCO here in Warm Springs. There are tribes. I do know that Yellow Hawk at Umatilla, Grand Ronde, Siletz, Cow Creek do have contracts with their local CCOs. Burns is too small. I don't think they do it. They're a very small tribe, and Coquille is very advanced as well. They're a small tribe, but they are very advanced.
So could you give us a sense of sovereignty?
Yeah.
What that means when you relate to OHA, when you relate to a CCO, those sorts of issues?
Yeah, so the main thing to remember when you think about sovereignty and the tribes is we are a government. We are a country, right? We're a country within a country. So when we have discussions with the state or the federal government, it's on a government to government basis. And each consultation or each meeting is really a negotiation, right? Because there's certain laws that have to be followed. There's certain criteria that has to fall under federal law. And then we're fortunate where Oregon is as advanced as it is on the state level, to where the state legislature over many years has passed favorable legislation recognizing the sovereignty of the tribes on the state level, and recognizing that federal status and working with the tribes in that manner. Tribes always have the right not to participate in any state program or not to receive funds or however that works, and to negotiate how those are processed through if we do decide to accept them.
So what aspects might that have an impact for us? Like, actually, as you were speaking, Michael, it made me wonder, so businesses that the tribe owns are a business in another country. And
Yes.
So from an employer point of view, what we're talking about with employers may not and does not apply to employers owned by the tribes.
That's correct. I think you got the right on there, John. You hit the nail on the head. Tribes would, a lot of tribes do have self-funded plans. Warm Springs has a self-funded plan. I know many tribes in Oregon have a self-funded health plan for their government employees, as well as their business, tribally business owned by the tribe, can participate in that as well.
How does Medicare work?
Yeah. Are tribe members eligible for Medicare and Social Security? And
yeah,
do you participate as a Medicare provider?
Yes, and yes. So we are. So Medicare is a federal program, right? And we're a federally recognized tribe, and we are still citizens of the United States. So we accept. We do get our membership is eligible for Medicare, and we try and get them. We actually help them get signed up when they turning 65. We trace them that year that they're turning 65 and help them through the process of enrollment and getting them set up through Social Security and Medicare.
Does the tribe help them with buying supplemental policies or going into Medicare Advantage plans?
Yeah.
Or do they?
There's availability to do that, right? So here in Warm Springs, I know Klamath Falls does that. They buy tribal sponsorship insurance for their tribal members, and that's an insurance policy. So if a person is on Medicare, whatever Medicare doesn't pick up, they pick up. If there's a service that Medicare doesn't cover, they'll pick it up and cover that. Here in Warm Springs, we utilize our contract health services, purchased referred care, to cover those services. So if somebody gets referred to someplace and Medicare covers a portion of the bill, Warm Springs picks up the balance through our managed care program here, which is what I'm the director of.
So they don't need to buy supplemental plans or Medicare Advantage plans?
No.
Right.
No. The benefit, I guess they could if they chose to, because the benefit with that is for those that have specialty pharmacy. The specialty pharmacy is so expensive, and there's certain rules on what can be covered and can't be covered in any health plan, right? So if you can't get them on a sponsored plan for payment of those, it gets very expensive for the tribe to cover those. They're thousands of dollars a month for some of those specialty drugs.
Right.
So in thinking about the roles of the single payer, Michael, do you have a suggestion on a way to describe the best you could see the relationship between the single payer and the tribe?
But this is going to take a thought process probably larger than my brain, because when you get into the single payer system, and what is covered and what may not be covered, and how does that get covered within a sovereign nation, right? A tribally sovereign nation. That's a whole that's a whole conversation that we could probably have in a different Zoom with probably another 5 or 10 people at the table with brain power to vet that out. But single payer, you know, the fear of single payer is somebody's going to get left out, right? Or something's not going to be covered. And that's why I think under the eligibility portion of the subcommittees is where, you know, there was the discussion of make sure that everything's covered.
So Bruce,
Can I
we're
make
gonna,
can
yeah,
I
Bruce.
make a suggestion? And Mike, I'd be interested in your thoughts. I think there's two different levels. One is the government to government relationship. And since the single payer is in essence an Oregon, you know, I would consider it an Oregon governmental entity, that one role is certainly, and to be defined, but the single payer to maintain a government to government relationship with tribes. And then we can figure out from there what that really means. The next level down is at the level of individual tribal members who, and I know this has been talked about in the eligibility tag, but that, you know, tribal members would have the ability to seek care within IHS tribal health systems, as well as to be eligible for the single. Does that get us in directionally the right spot?
I see a nodding of heads. Michael, you would agree that
Yeah,
captures
you always
kind of
want
the
to
essence?
you always want to have that relationship. You got to have that tribal consultation,
Yeah.
government to government consultation, and to get the support, right? If the support is there, then anything can happen as long as there's open communication and support.
Yeah, because when it comes to certainly the mission of the single payer in terms of equity and health disparities, you know, you could envision that there's a role in terms of investing in tribal health programs, prevention, those types of things, which are really different from the individual care piece of this. And you'd want to encourage that and have that be something that the single payer does.
Well, and if they're going to achieve health equity across, that certainly would be critical. So other thoughts on this at this point? We can try to capture some of this and bring it back to you to at least have some section of this governance overall structure that or description that at least notes this, knowing that there's much more detail to be worked out going forward. But
it seems like we need a legal opinion about this, really, in terms of you know, this must have been explored elsewhere, and I'd just be curious to know, you know, the people that have fought this battle before or organized it or whatever, what is the prevailing sentiment vis-a-vis a single payer and the autonomous tribes?
You know, I mean, it seems to me that we should follow Bruce's framework and look at, well, how best to have a government to government conversation, both now in this design stage. I mean, we've started because we have members of the tribes on the task force. Is there a point at which we should, as Michael says, go to an additional group of people to talk about the government to government piece of this? And then we should have a discussion about the implications at the individual tribe member level, and educate ourselves on how members of the tribe navigate Medicaid, commercial insurance, and Medicare, because it sounds like they do that. And then they also navigate the Indian Health Service. so this is another example of, well, there is federal dollars coming in via the Indian Health Service. You know, begin to try and figure out who's on first base, who's on second, and how do we not step on each other's toes as we move around the bases, because we want equity, but we don't want duplication. And
so if I can interrupt, John.
yeah.
So when it comes to Indian Health Services, the funding goes directly into the clinic to provide services, basic services. It isn't ever enough to
Right.
cover all services. But and when it comes to tribe self-funded plans, or it comes through purchased referred care funding, or some other funding source through tribes, the tribes are, by law, are always considered the payer of last resort. So any other health system or health plan out there would pay before the tribe always pays last. So if a bill is out there, Medicaid is primary to Medicare, and Medicare is primary to tribal. And private is primary to all.
Right.
So I'm interested in on the government to government stuff. My experience is in fishery stuff. I work for the Columbia River Intertribal Fish Commission, and so in the fisheries world, there's court created entities so that the governments are all at the table, right? Formally, and I got the sense that with CCOs today, it's sort of tribe by tribe, region by region, how often they communicate and what the structure for that is, if there is a structure. And so it just seems to me that to make sure that we do have a good government to government relationship, we should at some point be talking with tribal government leaders and their lawyers and whatnot about what would be a good thing to have. The state of Oregon has the commission. I think they have the Commission on Indian Affairs. And that's probably not adequate, and that isn't adequate for all the relationships between Oregon and the tribes. And so, we should design something as part of this, whether it's, a seat on boards or ex officio seats or whatever, so that there's government to government relations.
So,
Bruce?
Well, go ahead, Mike.
So Chuck, they have. The state has passed legislation that requires CCOs to have tribal liaisons on board with the CCOs. We have had discussions with OHA getting in the contracts to have tribal representation on those boards, those CCO boards as well. It's fortunate that you've been on the board or participated in CritFIC, because that is an example of what works, right? You have the 4 treaty tribes on the river, and they all have a seat at the table, and you have that government to government relationship, which involves other entities, as the Oregon Department of Natural Resources, as well as United States and United States Natural Resources, along with Bonneville. So that's an excellent example of how things can work. And I think having that government to government relationship is the key to that. In the healthcare system, to have that type of setup would be awesome. The closest thing we have currently for all tribes in the Northwest is the Northwest Portland Area Indian Health Board. And so when it says Portland area, just for clarification, that does not mean Metro Portland. Portland area, it covers the tri-state region. That's just the region that the Public Health Service, United States Public Health Service, has called the Northwest region. It's called the Portland area. So that includes Washington, Idaho, Western Montana, and Oregon. But that's 43 representations there. That's 43 tribes that they represent. It would be good to have something here in Oregon that just represented the 9 tribes.
And have the tribes talked about, the CRITFIC is this intertribal commission where the tribes, when they won the right to half the fish and to co-manage, they realized that they had small fisheries departments and they ought to merge their efforts and coordinate their efforts better to take on the U.S. and the states and Canada. And so has there been any discussion among the health entities at the different tribes? Or maybe we should have an intertribal health commission?
Bruce is smiling big because I think we talk about this all the time, don't we, Bruce?
Yeah.
we always talk about it, but we got to get the traction and do it.
The idea I've had is that we have a separate entity akin to the CCOs solely for the tribes.
We've been working on that.
Yeah, we're actually been looking at that as well.
Yeah. But here's the time to embed something like that.
Not to complicate things, but when Chad mentioned a legal opinion, it did raise a question for me that probably is worth getting a legal opinion about, which is if we were to create a single payer, tribal members are still, as Mike said, U.S. citizens and have certain protections under Medicaid and Medicare. So even if we were to set up a single payer, would there still be a Medicare and Medicaid option for tribal members?
All right.
So even if we got the waivers to do it for everybody else, what would happen?
You can often waive things for tribal members.
Right.
It's just something to.
Bruce,
we
just
might want
to
to
add
get an
on that,
opinion.
though, in theory, we could still create such an entity for the tribes and the CCOs, and it could be additive to their well-being, even if they have other rights and privileges.
Correct.
You were very helpful, Michael. This is great.
Right. And Michael, as I think about this in your description of, ultimately the tribes are the payer of last resort. I think when I think the language in 770, Oregonians would be able to get their health care wherever they want to get it. And I suspect the single payer would need to figure out how to pay for that wherever they want to get it. So figuring out how to do that in a way that best met the tribe's needs would be important. I mean, we would want them to go to their clinics in the tribes, or be able to go elsewhere, and we would be the payer. So interesting.
So I think we should probably move on if we're going to keep going, but we can continue to come back with some language, knowing that there's a whole lot of details to yet be developed at some point in time before implementation of the single payer. So the next sort of topic area is thinking about what the single payer entity, what it is in terms of structure, organizational structure. And in your slides that you saw before, and I won't read all of these, but we gave you some examples. The first two being state agencies, the Oregon Health Authority, which consolidated several things together, but is deemed a state agency. It has a director that's governor appointed, Senate confirmed. It gets federal funds, state funds, and other donations sometimes, and then reports to the legislature and is subject to the governor and subject to the legislature for a budget. And the Oregon Department of Consumer and Business Services, affectionately known as DCBS, is also a state agency. It's the regulator side of healthcare administers the health insurance exchange, does a lot of consumer assistance activities. Similarly, director is governor appointed, Senate confirmed. They are funded a lot from primarily fees collected from the programs they administer, and they have a consumer and business services fund, and then there are some, and then they also report to the legislature and the governor. The Liquor Control Commission was another example that we pulled out because they are sort of regulating things as well, alcohol and recreational marijuana. They are relatively newer on that last aspect, but they have executive director, similarly governor appointed, Senate confirmed. They are funded primarily by fees and taxes and bonds, and then report to legislature. So those are kind of three examples of different types of state agencies that are currently dealing with aspects of healthcare in some liquor control, depending on your perspective there. And then OHSU is a unique beast in that it is a public corporation. So it's both originally was probably more ingrained in state government, but is now more of an independent public corporation with as a research university as well as its hospitals. It became self-governed in 1974. It has a board of directors. It has a variety of funding, private, federal, state, and some state general funds. And that state general fund is submitted to the legislature, similarly to the public agencies. Next slide had a few more broader examples. The SAFE, State Accident Insurance Fund, is also a public corporation. Its focus is workers' comp. It has been a state agency since 1980. It's a nonprofit. With premiums, their funding coming from premiums and then some investment income and net gains off of that. And they have they work closely with the DCBS insurance division. There's workers' comp commission that sets some of the rules and policies around workers' comp. And then they're required to submit an annual statement to the insurance division. And then looking nationally, not that anyone's done single payer elsewhere in the United States yet, but Vermont Green Mountain Care Board is, even though it's called, the entity is called the Care Board, and they have a care board, so not to be confused. But they are, in Vermont terminology, a non-agency governmental organization. I'll leave it at that. But they, you had a one-pager in your background materials of some of its various tasks that we tried to capture most of here. They set community hospital budgets. They approve health insurance premiums. In Vermont's essence of, they're in the midst of trying to do a multi-payer ACO, or accountable care organization model. And so they're the entity that is overseeing that. They do a lot of also health policy planning, which does include certificate of need. They are funded through state general fund. They do assessments that gets billed, they bill back to go into the fund. And then, but the board members are state employees, but they're not in the state classification system. So it's sort of a unique beast within the state government. I didn't know they could only be removed for cause. We don't think we have that detail on all the others. The Alaska Mental Health Trust came to mind because of the COM 770 talking about a public trust. It's a state corporation. It really does operate more like a foundation in Alaska, but it administers the Alaska Mental Health Trust, which funds support for behavioral health care in Alaska. But the way they evolved, that they actually came from some of the tribal and other legal lawsuits that set up much of Alaska's unique systems in the sense that they were actually given land to be part of that they raise money off of the proceeds of. So if a cell tower sits on their land they own, they get revenue. If a pipeline runs across their land, they get revenue. If they sell some of their land, etc. So they have sources other than just the original trust fund. They actually they're supposed to live off of leave the principal intact and live off the interest of the money that was deposited after these court cases, and then also use the land as revenue generating to help support this. So they provide input to the state on how to spend the state general fund, and then they augment it with the money out of their trust. And then the Federal Reserve System was another model that was suggested to look at. It's an independent government agency. It is the central banking system. It's governed by a board of governors. It's funded by interest on government securities and other earnings. It's not subject to the congressional budget process and submits reports to Congress. So these were just the ones we came up with as some potential examples to think about. And we'll be sort of looking at some of these as we think about the boards what the board of the single payer would be as well.
How's the board of SAFE appointed? Do they self-appoint, or does the legislature get involved?
It's on our next slide, but it's governor appointed and Senate confirmed for SAFE.
That's what I thought.
So thoughts about these various entities. State agency, I guess, would be one category. Public corporation would be another. And then some sort of independent government entity. I guess the closest we have in Oregon is these public corporations of SAFE and OHSU.
Right.
Thoughts? John, you're muted.
I mean, for the record, let's just make sure that if you think there's some other organizational entity that we're not including. I mean, we don't have a for-profit publicly traded option here. We don't have a for-profit option here. I don't think, I wouldn't favor either one of those being on here, but if anybody disagrees, now's the time to say so. I mean, I think this needs to be a public organization that's publicly funded. Though we've talked about having the ability for people to make donations, and so maybe you could imagine a foundation subsidiary of some sort. And I liked the Alaska Mental Health Trust Authority as an example of the future may hold significant opportunities for a single payer to settle basically various disputes with others in a way that would result in revenue coming its way and being put into a trust fund like this.
Bruce, you're on mute as well.
I think the tension is between the organizational structure of the single payer and the revenue authority. In other words, I think we if we're going to rely on taxes that are set by the state legislature, that might point to the legislature wanting a little bit closer of a relationship. And one could see benefits of being both closer and further away from a state legislature. Certainly you don't want to get caught up in the politics of the state legislature, but you also don't want your funders stepping on your fund supply. And I mean, I think that's just a consideration. I don't know where I fall on all of these, but that's what I'm kind of grappling with in my head.
Yeah, and I think it was a really good point. So to John's comment about accepting donations, I've seen numerous bills over the years where just the way our budgeting and financial laws are structured in Oregon, the legislature has to authorize it's okay to accept money. Task forces typically have that in their legislation. And so I don't think that necessarily has to have a foundation, but I've been thinking about it also I agree with Bruce that the legislature is going to want some say, almost regardless of how much money, if they have a say in the policy. And I think of SAFE, right? So that's why they're involved with the SAFE board. They're not, what I've been thinking about is wanting to get a legal opinion from the AG, because I think Legislative Council has said this can't happen. But how do we take monies that are general fund, that now go to the general fund, and have them become other funds, so they avoid the kicker? That I think SAFE doesn't have to worry about the kicker. The Unemployment Insurance Trust Fund doesn't have to worry about the kicker. I don't think our healthcare should worry about a mistake, frankly. It's an honest mistake. It's not their fault that they can't project the right amount of money coming in, and healthcare shouldn't be subject to that. Yeah. And so I would love to get legal help about how we can move some of the current monies that are going into the general fund first and then to healthcare, to have it go directly into a special fund. From talking with Chris Allenak about the history of that, I don't think Legislative Council is going to be the creative one on that. I think it's going to be the Attorney General.
Well, Chuck, as you speak, it reminds me, again, I've been interested in Medicare, and, of course, you look at the Medicare Trust Fund, the Social Security Trust Fund. In many respects, the federal government has put them over to one side and said, these are entitlement programs, and so we have to be more careful about interfering with these funds. Although we all remember times when there were threats that they could do it, and you remember the Al Gore lockbox. I want to create a lockbox. For Social Security, and in some respects, I think you're talking about the Sheketoff lockbox. And I think about, I think it was your story that at one point the legislature or the governor wanted to take money from the SAFE fund. And
yeah, we did in the 80s, and we lost the lawsuit in the early 90s, and it took a lot to pay back.
Yeah, and business basically was a force objecting to the state doing that, right? That's what I recall.
Yep. Me too.
Yeah. So, and we did set up a health fund board trust box, so to speak. I think it only had $1 in it to open it up, if Bruce would remember from the days of early OHA. And I think it still sits there with $1 in it. But Senator Westland and Bates had an initiative to set up a health fund and a health fund board. And so there was statutory language. It's interesting, there's a bill right now to set up a brain injury trust fund, lockbox, so to speak, in statute that's before the legislature, or was at least a week or so ago, that used very similar language as we have in statute right now for that health fund board, health fund that sits there. But again, we have a session, I think a meeting or two down the line to talk about that sort of public trusts. I don't want to get us there yet because and we probably need to do a little more research to help bring you back some more information about that. But as you think about, I don't know if it necessarily has to be that if it's a state agency, does it have different ability to sequester those dollars versus a public corporation? We do know that, OHSU's other dollars are not subject to state general fund whims. SAFE, as you just mentioned, is another public corporation that has different types of a lockbox, so to speak, that may or may not be locked. So I guess the thoughts are, what would you, if you had to say that it sounds like it's agreeable that it's a public entity. And I guess thinking about what type of oversight, consideration of the legislature, who is a key funder or a diverter of funds to this. Other thoughts about an appropriate structure, as we know that we'll need to get into more details about the dollars themselves.
Can I ask, Janine, what is the SAFE structure? Is it a public corporation?
Yes, it is a public corporation.
It's a nonprofit public corporation. It has a board.
Right. Correct.
And
state-chartered nonprofit.
So my understanding is we have three, and Bruce and I had a good conversation with Ted Kulingoski about this. There's basically three public corporation is used both specifically for, I think, SAFE, but it's used in general for OPB, OHSU, and SAFE. And some of you will recall there was a move to make under Wheeler to make the Treasury was going to try to become a public corporation. They're all defined differently, slightly different structures under the general title of really a public corporation. That the people who work there are getting SAFE monies. That the legislature has a say in their boards, some of them, not with OPB, for instance. I don't believe the legislature has to confirm them. They get appropriations though, right? And so, so I want it to be a public corporation and then sort of pick the best features or the right features from the ones we already have or don't have. And from my perspective, it would be to somehow figure out how because the entity is going to have a lot of general fund dollars that are subject to biannual appropriations and the kicker. And I'd like those dollars to not be subject to that.
Right.
I think that's the issue. That's the difference between something like SAFE, which I believe, and I could be wrong, Janine, maybe you know this better than me. They set their own assessments of employers. And so
right.
they assess and they set the assessment and they collect it. They don't rely on the legislature to do that.
Right. But the legislature can intervene if it wanted to. I mean, it's sort of like the Unemployment Insurance Trust Fund. The legislature established the tables that are in statute, but on an annual basis, the employment department decides which tax table they're going to use, and they have their standards based on some statutes of what level you as an employer are going to have to pay based on your layoff history. And it's only when someone wants, like now, they want to exempt some people from the new rate that's going to go into effect because the trust needs the money. But that happens pretty much, it's very rare that the legislature gets involved with rate stuff with unemployment insurance.
Right.
The other aspect that gets back a little bit to the lockbox and trust issue is significant portion of the money coming in from the single payer is from the federal government. And I can only imagine that the federal government would go, well, okay, you guys said you were going to do things differently in Medicare, and you did. And it looks like you've profited to a very significant degree. We'd prefer you keep that money in a lockbox to be used to the benefit of the Medicare population going forward. You know what I mean? I mean, I would think the federal government would not be very happy if the Oregon legislature said, well, you had a $500 million excess from the federal government on the Medicare side, and we want that.
John, I think you're quite right. I think that it's going to be part and parcel of any waiver.
Yeah, that's the SAFE lawsuit, right? The businesses were paying workers' comp, and the legislature said we needed to pay for other general fund stuff, and so they went to court and won big.
So there seems to be some leanings towards potentially being a public corporation versus a state agency. Is that correct? And
I agree.
Some features of being potentially being able to accept funds in sort of a foundational sort of way, a la the Alaska Mental Health Trust potentially. And then, of course, some further work on, as I think Chuck put it, the right features to ensure the stability of the fund for Medicaid, Medicare, and everything else.
In my mind, it is a trust fund. You know, the bill has this sort of awkward public trust language scattered throughout it, and that it really does become a trust fund. And you know, and I'm not so into the foundations thing, but that it be allowed to have its own rainy day fund that is allowed to build up reserves so it can weather economic downturns.
Chuck, this is a question about this. Does the state currently access, I don't know, interest on payments or any other form of revenue through the Medicaid program, for example, that it puts into other purposes?
I don't think so.
No.
No. So, you know what they you know, when Ben Westland was chair of Ways and Means, there was some extra Medicaid upper payment limit money coming to the state, MUPL.
Yeah.
And so there was going to be a kicker. So he moved it because under our normal way of doing budgeting, that MUPL money was going to go into the general fund and be subject to the kicker. And so he moved it out of there. And it went to the Supreme Court, and you know, the state won.
The feds ended up getting that money, clawing back that money anyway.
You mean, Bruce, I'm out of date maybe, but is there still the direct and indirect expenses at OHSU and around education?
Yes.
That's a gray area, right?
Right.
Yeah, hardly thought over. Very, very,
Right.
yeah.
And then there's also the self-insured reserves for PEB in order for them to be self-insured that are protected somewhat.
And PEB's funds are all other funds.
That does bring up the notion of reserve and solvency, which will be an element that will need to be understood fully in terms of what will be required from a solvency and a tangible net reserve standpoint.
Yeah, you know, it seems to me that the public corporation might be the better structure for us to deliver on what will likely be significant fiduciary responsibilities.
Right.
Significant.
and its ability to build and survive, build a rainy day fund or adequate reserves to weather economics, is really important, and especially if we're not successful at reclassifying the general fund dollars as outside the kicker, right?
Right.
Because like the employment agency does an analysis annually about whether or not they have enough money, and if they don't think they're going to have enough money for that 100-year flood of unemployment, everybody's taxes go up a little bit. And there's like 6 or 8 or more tax tables that are in the law that don't get looked at very often because they keep the system funded.
Well, I think we have at least a general concept here of public corporation, trying to find the right features, and a lot to think about for the fiduciary lockbox. So with that, let's move on, Laurel, to the next, which is the governing boards. Again, we sort of mirrored the structures of the entities you'd already discussed. As John and Bruce are very well aware of, there is the Oregon Health Policy Board, which is really more advisory, I would describe, for oversight for OHA. Governor appointed, Senate confirmed. They're paid. I think travel is paid, but that's about it. OHSU Board of Directors, another as a public corporation, it does have governor appointed, Senate confirmed, but not paid. I don't know about travel. SAFE, similar, governor appointed it, and I dug a little further. They are Senate confirmed, and there is some linkage in their statute to getting the $30 a day plus travel, but certainly not a significant salary for their time. And then the last one there, OLCC, similar setup as those above. And then I think the next slide has a few more examples for you. So Green Mountain Board, which oversees the Green Mountain Board, has 5 members, governor appointed, Senate confirmed, 6-year terms, and they're paid state employees. So a very different sort of approach. The Mental Health Trust Board is paid honorarium, per diem, and travel expenses, which can be high in Alaska, but not significant like a paid salary like the others. And then the Federal Reserve they are paid. They're paid an annual salary. So these were sort of some we thought would be some good examples as we are, sort of leaning towards. And now that you're more leaning towards public corporations, something to think about.
Yeah.
Thoughts from anyone so far about these?
Well, I mean, I think you can deal with how many members there should be later. That can be a short or very long and tedious discussion. I personally feel pretty strongly that if you're going to be responsible for $40 billion, you should have folks who take that on for a living, that they are paid. And they take it seriously. They're very accountable. Governor appointed, Senate confirmed is just fine. You're talking about people who are really going to need to make a commitment. I also think that the board should truly include folks who are not healthcare folks making money at other businesses, and part of it is rewarding them so that they are not tempted to try and make money in other ways. And you want to have non-healthcare, more consumer-oriented folks.
John, I guess my only comment on that is I have lots of experience in running hospitals by elected district boards. And a lot of those people are lay people. And it can be a danger. And I'm not speaking for the professional, and I certainly think they can't be otherwise engaged, but I just wonder the merits of having people that are well-intentioned but do not have the requisite skill set we're looking for.
I think that's a really good point. I see it sort of like the Northwest Power Planning Council, which handles millions, if not billions of dollars. So I can't remember what legislators are now on it, but Bill Bradbury used to be, and they get paid a fairly good pay. They're governor appointed, Senate confirmed for certain terms. And, they put in a lot of time. He wasn't a fish scientist. Oh, Devlin was the most recent one, and Ferrioli went to it. Both of those are now on it, I believe. And, they weren't picked because they were fish experts necessarily, although Bill did some work in that area, but they can handle lots of money and policies. And so I think that's the type of quality of people we would want on our board.
Yeah, I remember, the previous administration, there were a couple of controversial Federal Reserve Board member nominations. And, the Federal Reserve Board, they again tried to make them nonpartisan. And I mean, you look at the qualifications that those folks have, they know their stuff. They are incredible economists, lawyers, et cetera. They know their stuff. And it seems to me that's the kind of bar we should set. I hear you, Chad, and I would say these should be people who no one would question their competence. And Chuck, I think you're on the right track with the organization you're mentioning.
Bruce?
I just I would agree with the need for expertise. On the other hand, I would just point out the need to balance that with a community voice and a voice from particularly communities that have experienced health disparities and aren't represented and don't have good access. And we have a history of putting together boards that very much look like and think like, a very dominant culture that hasn't often done all the things that we'd like them to do. I think there needs to be a balance.
We can also have a robust advisory group as well. So I think your point's well taken, Bruce, and I think we do need to be sensitive to it, but maybe the governance board is not the only entity that we have in this structure.
Right, and I'm not appointing, but I think of someone like Michael, who would, if he said, yeah, I'd love to apply to the governor to be appointed to that, and it'd be his change of job. He represents one of those communities. I mean, I just think it's it's a professional thing, not from those communities. I think we absolutely need to make sure we're meeting those needs, Bruce.
Yeah, on OHPB, we visited the Umatilla Reservation, and we met and had dinner with the board of the tribe. They are impressive. And any one of those board members is more than sophisticated enough to qualify. So I don't think it would be a problem to find those folks. I do think they would deserve to be compensated, supported in various ways by staff, those kinds of things.
This would actually be an agency, right?
That's going to be a public corporation.
It's an entity. And so it's possible that this executive group could also have their own executive.
Well, that's like in SAFE, Carrie Barnett currently is the executive director, He's got staff. I think there's about 1,000 employees technically in SAFE as one example.
Right.
And there's, if you look at their minutes, they have, the board decides about executive compensation, staff, employees, etc. So yeah, you would think there would be an executive director plus the board.
Right.
But although we didn't explicitly put that there, but we can, if you all agree that there would be sort of an operational staff, right?
Absolutely. I mean, the staff there, they're working for a public corporation, but they are public employees, right?
Right.
Janine, can I just ask Laurel if we have any public testimony and folks who are at the meeting, if anybody wants to speak here or in the last 15 minutes. Laurel?
So we did receive the written testimony that I sent out. I don't know, David, were you hoping to speak to that testimony as well?
Yeah, I was hoping to be able to speak a little bit to it anyway.
Is there anyone else on the call? If you could unmute yourself and let us know who would wish to give public testimony. Okay.
So what I'm hearing for this is we try to wrap this up, and so we can allow time for public testimony, is there seems to be a leaning towards a public corporation that would have a board that is governor appointed, legislative confirmed, I think I was hearing by several of you. And there was a tendency, some of you felt important to have more like the, I guess the Federal Reserve Board or the Green Mountain Board be paid state employees or be paid a salary in some way. Is that what everyone's agreeing to at this point? Again, this is all going to come back to you next time.
I agree.
And that also there was some talk about ensuring adequate expertise, but also adequate community voice. And on the board itself, plus potentially supplemented by a community advisory committee. I mean, we wrestled with that with CCOs, where the statute for CCOs is that they do need to have a member of the community on their boards, and as well as certain other stipulations they put into statute there, rather than just an advisory board that is not always guaranteed to be heard at the board level.
Right, and I would probably add regional distribution, Janine.
Right. I was going to say representative or some kind of representative of each of the regions that we end up having in this structure.
So the board would be 20,000? No, field.
Well, I don't know about the board. It could be another advisory group or something. I just think that there needs to be a vehicle for these regional entities to participate in the policy process in an organized way.
I mean, I think the Federal Reserve commissioners cover the country. They're regional. I don't know if they all work in DC, but.
So,
No, they don't.
Well, no, I think that many of them are across the country.
Right.
They're all around the country.
They represent certain regions.
Right, and there's the Central Federal Reserve Board.
Right. Okay. So I think the last question was, are there specific questions we want to push on to the Consumer Advisory Council related to the various discussions we've had today around roles, structure, governing board?
Ooh. There's a lot of it they would care about.
And Laurel, they will see the next rendition of this at some point.
Well, I think there's a.
Go ahead, Bruce.
I think there's a big question to ask the Consumer Advisory Committee, which is, I'd like to get their thoughts about assuring in terms of a board or an organization, what are their thoughts about assuring an authentic community and consumer voice?
You know, I think we could frame a question asking them, are there organizations you think of that you think are, you know, particularly trustworthy because of their inclusion of the consumer and community, or, you know, something, we can work on something along those lines. I agree, Bruce.
I like that, John. And I think the issue of how do you balance expertise with, you know, with community needs and desires.
All right. So Laurel, next meeting is April 15th, and we're going to focus in more on the role and structure of regional entities, and we'll bring back a summary document based off of today, which you'll certainly see before then. But I don't want to lose time for our public comment.
I am so impressed that you guys got through that agenda. I just have to say that. That was really impressive.
Okay, should we go to a public comment?
Yeah, great.
David, the floor is yours.
And this might not take too long unless there's questions or discussion. But yeah, I think a lot of people have seen me comment in meetings, this one and others before. I've been watching the 770 legislation, and I periodically reread it. And I see the task of this group is to define what kind of entity it is legally and fiscally, and what authority it has. But from my reading of the 770 legislation, that happens later on. And I see a lot of things in the 770 legislation that are written as imperatives, and a lot of other stuff that are implied as imperatives, that there needs to be a lot more baseline data. And I have seen none of that coming from any part of the task force. But the 770 legislation as written is saying that all over the place. And I highlighted, you know, I sent along a subsection of the 770 where I highlighted things. But I think that needs to happen before this can even be submitted to the legislature, and the legislature then approves like the structure and the board structure and the feedback on the board structure, and is it succeeding?
David, thank you. First of all, if you all haven't had a chance to look at what David submitted, I urge you to do so. I really appreciate you submitting that testimony. I think, David, we had a somewhat similar discussion at Finance and Revenue. In part, that came about as public testimony from Charlie Swanson, who urged that we develop a more explicit list of the expenditures that were likely. And I think, Chuck, correct me if I'm wrong, there was agreement at Finance and Revenue we should do so. And actually Warren George testified yesterday that he was preparing a document kind of along those lines. And so we appreciate you bringing that to our attention. I think we agree, and we need to do that. I do think, David, there was a discussion yesterday at Finance and Revenue that emphasized that committee's feeling that we aren't going to get to the point where we're going to be able to satisfy all the requirements in 770 and in terms of reporting. We need to be authorized to go beyond, June. We hear you.
Not only go beyond June, but get some additional resources to hire technical expertise.
Chuck?
Chuck, did you have
Got
something?
it. One of the takeaways from, Charlie's presentation and 25-page memo is there isn't a lot of good data out there. And there's clearly not a lot of, good data as far as the most recent year or whatever, current or most recent year. And so, I think, I'll be a little more defensive than John. I think we are trying to pull those numbers together. And, in hindsight, I think we gave the impression we were relying more than we are on the RAND study. That was used as a sort of starting point to get what ballparks we're in. Are we in the really big stadiums or the smaller ones? But I think we are trying to get that together. And I think in the intermediate issues group that Bruce is heading up is also looking at how to get better data and whatnot. So it's a system that we had, one chart on revenue that was called "It's Complicated," and the people who put it together said it doesn't have all the lines in it, and it clearly sort of was the best named chart ever. Maybe our whole task force should be called that. But so we're trying. We recognize that, and I guess we also came to yesterday. I think we talked about how at some point when the legislature actually wants to do this, they're going to need to bring in actuaries and whatnot to make it work. But Bruce is right. We need money for some experts and to get time out of Legislative Revenue Office, Legislative Fiscal Office, and a number of the agencies to get the time to pull the numbers together.
In the last paragraph of the kind of the letter I put in there, and I talk about Bayesian analysis or program evaluation structures. And you start out with as good as you can get. And then you refine it as you get better data and as you get more experience. So we don't need perfect data to start with. I think we need to frame the questions that need to be asked and answered. But, put out a starting point and that's better than nothing.
Have you been following the Finance and Revenue Committees?
Not firsthand, no.
So I'd encourage you to at least go to the website and look at the documents, the staff summaries of the meetings and the slide packets and whatnot. There is one advocate, Lee Mercer, who confessed that he listened to all of our TAG audios and videos. But I would suggest that you at least look at those, because I think you'll see that we are, trying to get as much information as possible. So.
Thank you.
But appreciate you participating in this one.
Any other comments? Hey, we got some nice weather.
And I got my shot this morning, and I have not had any side effects yet, which is nice. So
yeah, keep
it's
your
my
fingers
second
crossed.
shot.
I'll see how tomorrow goes.
Yeah, Chuck, I walked 10 miles 2 days after my second shot. On the other hand, one of the fittest 70-year-olds I know was kayaking 2 days after his second shot and had the sudden onset of what, if I was a practicing doctor, would say was a foodborne, incredible, toxic illness. Mm-hmm. He immediately began vomiting, nausea, vomiting. It continued for 2 or 3 hours. He recovered the next day, but a very profound illness. And he assured me he hadn't eaten anything bad. And, indeed, you go to Moderna's studies and nausea and vomiting is there 27% of the time. but it was profound. He had quite the profound illness. So we'll see.
He'll do fine,
Fingers
Chuck.
crossed.
Yeah.
Fingers crossed.
Okay.
Take care, everybody.
Right.
Michael, thank you for coming. Janine, Janet, thank you. Laurel,
Yeah.
Sarah, thank you. David, thank you.
All right. Thank you, everyone.
Yeah, thank you, everybody.
Thanks.
Bye-bye.
Sarah, if you could stop the recording when you get a chance.